Thank you to Professor Rosenfeld, Professor Ranganathan, and the North American Cystic Fibrosis Conference Organising Committee for inviting me to speak today on the topic of early airway infection and the microbial community. It really is an honour to be here. Before I begin, I have no disclosures relevant to this presentation. Today, I'm going to focus on two topics. First, the lower airway microbiota in early cystic fibrosis lung disease and its association with treatments and with clinical outcomes. And second, the very long-term outcomes following early lower airway infection in cystic fibrosis. I'm sure that you're all familiar with slides like this one, taken from what is now an old Australian Cystic Fibrosis Data Registry report and demonstrating the historical understanding of infection in CF, with 1 to 2 of a relatively small group of well-recognised pathogens detected on standard culture of lower airway samples, or of any airway samples. We understood that there was a progression of sorts in CF airway microbiology, from Staphylococcus aureus and Haemophilus influenzae in early childhood to Pseudomonas aeruginosa and other gram-negative organisms in later years. While this is to some degree is true, the lower airway microbiota, referring to the entire microbial community, and for the purposes of this talk, the entire bacterial community, actually looks like this. In this figure, you can see the lower airway microbiota of individual children and its progression through infancy and early childhood. Each column represents a single BAL, and each group of columns represents serial BALs from an individual patient collected during the first 5 years of life. Each colour represents a particular genus, and they are displayed in terms of relative abundance, so that the tally is always 100%. In this figure, the dark blue represents Streptococcus, the light blue represents Staphylococcus, and the light green represents Pseudomonas. And as you can see, in early life, the lower airway microbiome is dynamic and is often relatively diverse, and then becomes dominated usually by a single genus, usually correlating with a typical pathogen, for example, Pseudomonas or Staphylococcus, and then often returns to diverse again. The lower airway microbiota of infants with CF is, however, different from that of infants without CF, and these differences are established in the first 6 months of life. In this study, we compared the microbiota of 13 infants with CF who had BALs collected at a median of 1.8 months of age, and 9 control infants who underwent clinically indicated bronchoscopy, generally for evaluation of stridor, at a median of 5.6 months of age. Of the infants with CF, 60% were stable at the time of BAL, and the remaining 40% were unwell, with respiratory symptoms or antibiotic use or both. And as you can see here, the lower airway microbiota is profoundly altered in infants with CF compared with controls, more so in those who are unwell at the time of sampling. To explore this further, by looking at alpha diversity metrics, you can see that richness, the total number of genera in a sample, displayed here in the middle panel, was significantly reduced in infants with CF compared with controls. There were no statistically significant differences in either Shannon Diversity Index or Pelo's evenness between the groups overall, although there were reductions in both indices in unwell infants with CF. Inter-individual differences were also greater in the unwell infants with CF, represented here by the green triangles, compared with the controls represented by the purple squares. From early childhood, it is evident that in individuals with CF, particular features of the microbiota are associated with inflammation. In this longitudinal study of 95 BALs from 48 infants and children with CF, aged between 1 month and 6.5 years of age, diagnosed predominantly by newborn screening and not treated with prophylactic antibiotics, reduced Shannon Diversity Index was associated with elevated lower airway inflammation, even after adjustment for age. And here you can see interleukin-8 on the left and neutrophil elastase on the right. In this study, dominance of a genus corresponding with a known pro-inflammatory pathogen, red triangles representing the Staphylococcus dominance here and the blue crosses representing Pseudomonas dominance, was associated with both reduced diversity and increased airway inflammation. In other analysis of this cohort, we demonstrated that bacterial biomass was associated with increased interleukin-8 in the first 6 months of life. The ACF-BAL study group has examined different characteristics of the microbiome in BAL samples from 78 children with CF, obtained between 4.5 and 5.5 years of age, and clinical outcome measures. They reported a significant relationship between alpha diversity and neutrophil count, and between predominant taxa absolute load and both inflammation and structural lung disease. The strongest association, however, was with total bacterial load, as defined by quantitative PCR. And as you can see from this figure, total bacterial load was correlated with neutrophil count, with interleukin-8 concentration, and with severity of structural lung disease as measured by the CFCT score. ARREST-CF has also demonstrated an association between the early life microbiota and clinical outcomes. In this study, they examined the lower airway microbiota of 46 Australian preschool children with a median age of 1.95 years. Australian children in this study were routinely prescribed antibiotic prophylaxis until 2 years of age. The study demonstrated or found 3 distinct clusters of taxa in these BAL samples. Cluster 1 contained 7 taxa generally associated with the environment or found in their background controls. Cluster 2 contained 10 taxa typically associated with the oropharynx, including Streptococcus, Villanella, and Prevotella. Cluster 3 consisted of 6 taxa, typically recognized clinically as pathogens, including Haemophilus, Staphylococcus, and Moraxella. The study found that the different clusters were associated with age. Cluster 1 samples with the environmental dominated pathogens, the environmental dominated genera were most prevalent in infants. The cluster 3 dominated samples, so cluster 3 was the typical pathogens, were more prevalent in children aged above 4, and cluster 2 with a taxa common to the oropharynx were most prevalent in the intermediate age group. This suggesting that in the context of antibiotic prophylaxis in the first 2 years of life, there is a progression of the lower airway microbiota from relative sterility in infancy to dominance of taxa common to the oropharynx, and then to dominance of more traditional pathogens by 4 years of age. The study also demonstrated an association between microbiota composition and clinical phenotype, including bacterial density, total immune cells, total neutrophil counts, and bronchiectasis scores, which were increased in participants with cluster 3 dominated or the typical pathogen dominated profiles. We have also compared the lower airway microbiome of 17 Australian infants with a median age of 3.5 months who were treated with antistaphylococcal prophylactic antibiotics, and that of 15 North American infants of a median age 6 months who were treated with antibiotics only as required for respiratory symptoms. As you can see here, with BAL in the top panel and oropharyngeal swabs in the bottom panel, that the infants prescribed antibiotic prophylaxis, represented in red, had reduced Shannon diversity index and reduced alpha diversity compared to those prescribed treatment antibiotics only. However, in contrast to the previous studies, those infants prescribed antibiotic prophylaxis, the red circles again here, had significantly reduced absolute neutrophil count and reduced Shannon diversity index was associated with both reduced absolute neutrophil count and reduced interleukin-8 concentrations. Moving on now to the second part of my talk, what are the long-term health outcomes associated with early life lower airway infection in infants with CF? I have recently completed a long-term follow-up study of the Victorian cystic fibrosis birth cohort. This is a birth cohort of 100 infants that was established at the Royal Children's Hospital in Melbourne in 1992. It is of note that newborn screening for cystic fibrosis was introduced in Victoria, Australia in 1989, and this study was designed with the aim of exploring lower airway infection and inflammation in infants and young children with CF. Eligible infants were born and diagnosed with CF between 1990 and 2001. At the Royal Children's Hospital at the time, the practice was not to use routine prophylactic antibiotics, and so these infants were treated, as in many parts of the world now, with antibiotics as required for respiratory symptoms or evidence of lower airway infection. Participants underwent bronchoscopy and bronchoalveolar lavage at recruitment and annually thereafter, as well as during hospitalisation for pulmonary exacerbation. They were treated at Victorian specialist CF centres, so at the Royal Children's Hospital at the time of diagnosis and recruitment into this study, and then later at Monash, some of them at Monash Health in childhood, but all of them were transitioned to the adult CF services at Monash Health and Alfred Health in adulthood. And most, I must say, remained in Victoria, as is more common in Australia than in parts of the US, I understand. The 25-year follow-up study I conducted had the aim of exploring the very long-term outcomes following lower airway infection with Staphylococcus in the first 2 years of life and lower airway infection with Pseudomonas aeruginosa in the first 5 years of life. I was specifically interested in the impact of these infections on survival or need for lung transplant and on the rate of decline of lung function using FEV1% predicted, defined using the GLI reference equations. Of the 100 participants in the initial birth cohort, there were 79 participants in this follow-up study, including 52 adult patients of the Victorian CF centres who had a median age of 25 years at the end of the study period, and 26 members of the original birth cohort who had passed away at a median of 17 years of age. I also could include limited follow-up information from one participant who had relocated interstate in childhood. For all further analysis, and as you can see from the table on the slide in front of you, those who have had a lung transplant have been grouped together with those who had passed away, which was a total of 29 or 37% of participants in the follow-up study. Those who had deceased were born on average 1 year earlier than those in the survivor group, but otherwise there were no significant differences between the two groups. 45% of participants were male, 2/3 were homozygous for the CFTR mutation 508del, and diagnosis was early at a median of 1.2 months of age via newborn screening in 3/4 of participants and following presentation with meconium ileus in 18%. In total, participants contributed 221 lower airway samples, which is a median of 3 per participant. Almost all were BAL samples, a small number were sputum samples, and 1 was a biopsy sample. 60% of the samples were obtained in the context of respiratory symptoms, and 50% were obtained from participants taking antibiotics at the time of sampling. 69 participants in this study had at least one lower airway sample collected prior to 2 years of age. Of those, 43, or almost 2/3, had Staphylococcus aureus detected on at least one occasion. And as you can see from the figure here, there was no difference in survival amongst those who had Staph aureus in their lower airways compared to those who did not. There was also no difference in the survival of participants who had Staph aureus detected in a lower airway sample in the first 2 years of life compared to those who had no pro-inflammatory pathogen at all detected. And pro-inflammatory pathogen for this analysis included Pseudomonas aeruginosa, Haemophilus influenzae, Stenotrophes multifida, Burkholderia cepacia, Acinetobacter, Achromobacter, and Aspergillus fumigatus. As you can also see from this slide, there was no difference in survival related. So difference in survival was not related to Staphylococcus aureus concentration. So those with increased concentrations of staph above 10⁵ colony-forming units per mil also had equivalent survival to those who did not have Staph aureus detected at all. We then used a linear mixed effects model with random intercept and random slope to examine the rate of decline of FEV1% predicted. And as you can see here, there was really no difference in FEV1% predicted at 5 years of age or in the rate of decline of FEV1 over 25 years in participants who had lower airway infection with Staph aureus in the first 2 years compared to those who did not. Looking now at Pseudomonas, all 79 participants had at least one lower airway sample prior to 5 years of age. Pseudomonas aeruginosa was detected in 28 participants, or 35%, and this included the OST1 as Pseudomonas strain in 8 participants, or 30% of those with Pseudomonas infection. And as you can see from this Kaplan-Meier curve, detection of Pseudomonas in the first 5 years of life was associated with a significant reduction in survival. Separating that out further to look at the impact of infection with the OST1 Pseudomonas genotype depicted in red, compared with the absence of Pseudomonas infection in black, or the non-OST1 Pseudomonas infection in green. And what you can see here is that the OST1 Pseudomonas was associated with significantly increased risk of death, the hazard ratio being 7.8. The hazard ratio for infection with non-OST1 Pseudomonas alone did not reach statistical significance, although there is a reduction in survival or a trend towards reduction in survival, as you can see. Looking at concentration of Pseudomonas, you can see that survival was significantly reduced for those with Pseudomonas presence in concentrations of above 10 to the 5 colony-forming units per mil, and this analysis had a hazard ratio of 3.3. I suspect that actually the true relationship here is stronger, because I do know that some of the samples obtained from the more unwell children who were expectorating sputum and the one that contributed a lung biopsy did not undergo quantitative analysis and so were not included here. Moving to lung function, the linear mixed effects model suggested that FEV1 at 5 years of age was 4.4 units lower in those with a history of early life Pseudomonas infection, and that the rate of decline was over time was almost 0.5 units per annum faster in this group. These results didn't reach technical statistical significance, but I do think that this is a trend that would be replicated if we had increased numbers. The findings don't change after adjustment for gender and genotype, and they also don't change after accounting for the different types of Pseudomonas infection, those with the OST1 genotype and those without. And I think it's important to note that really that is because this is already a survivor cohort. Those infants infected with the OST1 Pseudomonas in the first 5 years of life typically did not survive to be able to contribute lung function. So, putting all of this together, you can see from the data that I presented in the first part of the talk that the early CF lower airway microbiota is both diverse and dynamic. Perturbations and differences from that of control infants are established in the first 6 months of life, and structural and compositional components of the lower airway microbiota are associated with clinical outcome measures. Whilst in early childhood, the lower airway microbiota is dynamic, the factors that drive the development of the CF airway microbiome are not completely understood. But it is very clearly the subject to manipulation by continuous antibiotic exposure. And so the question I would ask of you is, should we be manipulating it? Should we be using anti-staphylococcal prophylaxis? And so then we look at the second part of my talk. And I think the conclusion from my long-term study is that in the context of newborn screening and symptomatic management at specialist CF centres, lower airway infection with Staphylococcus aureus in the first 2 years of life did not have an impact on long-term clinical outcomes. And as we have discussed at my CF centre at the Royal Children's Hospital in Melbourne, we have stopped using anti-staphylococcal prophylaxis on the basis of this, but I will leave it to the following speakers to add to that debate. And so with that, I would like to thank you all for listening. I would like to extend my sincere thanks and appreciation to the Victorian Cystic Fibrosis community, who has been supporting this research for over a quarter of a century. To my research supervisors, Sarah Thranganathan, Keith Grimwood and David Armstrong, to the Respiratory Diseases Group at Murdoch Children's Research Institute and the Department of Respiratory and Sleep Medicine at the Royal Children's Hospital, to the CF services at Alfred Health and Monash Health, the team at the Australian Cystic Fibrosis Data Registry, and as well to our collaborators at Washington University of St. Louis, to Stephanie Davis at the University of North Carolina at Chapel Hill, Ben Marsland at Monash University in Melbourne, and Geraint Rogers at SAMRI in Adelaide. My sincere thanks. I would like to thank those who have provided fiduciary support for this research, including the NHMRC, the College of Physicians, and the Royal Children's Hospital Cystic Fibrosis Trust and Cystic Fibrosis Australia, as well as the Thoracic Society of Australia and New Zealand. Thank you. Thank you all.
Hi, my name is Kevin Sutherland. I'm a children's doctor working in Liverpool in the UK. Thanks to Margaret and to Sarah for asking me to contribute to this really interesting symposium. They've asked me to talk about controversies in Staph aureus prophylaxis. I'm a little anxious about the word controversies because it kind of gives a suggestion of something bad happening, but I don't think there is. I think that there are different approaches to Staphylococcus aureus prophylaxis, and those approaches are reasonable in their own way. But it does give me opportunity to talk about an ongoing study that we have in the UK, the CF study, and this is a study that's funded by our government through a funding stream called the HTA. I have no conflicts of interest. I just wanted to highlight what a large group of collaborators are involved in this study, and particularly to highlight the Cystic Fibrosis Trust, who are a disease-specific charity based in the UK, and they have funded and they provide a home for the national CF registry for people with cystic fibrosis in the UK, and we've been employing that registry to provide a framework for the CF START study, and I'll talk a little bit about that later on. So I've been reflecting recently, and I've just written an editorial for the Journal of CF around what are we trying to achieve for these babies, particularly now that newborn screening is established in so many countries, and we have these very well babies delivered to us at 6 to 8 weeks of age. So what are we trying to achieve? Well, we're trying to achieve entry into school with a child who is who has excellent respiratory health, and by that I would mean that they have no significant long-term respiratory symptoms, certainly no cough, no bugs isolated on their respiratory samples, and normal imaging, and I would say also a normal respiratory function test, and that might be their lung clearance index as measured through a multiple breath washout test. That's what we're trying to achieve, and there's clear consensus on the need to address nutritional issues, so the need to address pancreatic insufficiency and achieve nutritional excellence. There's no debate about that. There's also clear consensus on the need for a healthy lifestyle, avoiding cigarette smoke, and exercise is really important. We know that for adults with CF and for children now. But there remains considerable varied practice and approaches with regard to how do we achieve airway health, and some areas of debate I won't cover today, but around airway clearance, like physiotherapy, we call that in the UK. How often should we do that? What techniques would we use? Aerosolized therapies, what should we be delivering to these preschool children, and how should we deliver and when? These are all areas that we're beginning to get a better evidence base, but still areas of variance. But the biggest area of debate is around antibiotic strategies, and there's a number of components to this. Respiratory surveillance. How do we get respiratory samples from babies and from preschool children? Do we use upper airway samples as a surrogate for what's going on in the lower airways, or do we just do less frequent but more definitive lower airway sampling through a bronchoscopy? So there's consideration about that, how we do that. Cough swabs in the UK, nasopharyngeal aspirates in Europe and in the US. And when we get a positive culture result, how do we respond to it? Do we treat asymptomatic children? Do we respond to all the bugs that come to us? But probably the biggest area of debate is around, should we have children on antibiotic prophylaxis, specifically anti-staphylococcal prophylaxis, or should we treat them in a more targeted way with antibiotics given if the children are symptomatic or if they grow specific bugs on their respiratory cultures? If you just let me talk about the UK approach for a moment. In the UK, our guidelines suggest anti-staphylococcal antibiotic prophylaxis is recommended until 3 years of age, and flucloxacillin is suggested. And in the UK, we have a vast amount of patient years experience using this very narrow spectrum antibiotic in this age group, where it has a very good safety profile. Most units would carry on using it for even longer, and even some adult centres in the UK use anti-staphylococcal antibiotic prophylaxis. And this kind of practice is based on a sort of history of a legacy of workers in the 1960s like Margaret Mears, who very carefully epidemiologically defined what sort of pathogens were seen in children with cystic fibrosis over the course of their life, and showed this graduation from Staph aureus and Haemophilus through to Pseudomonas later on. And the hypothesis and the rationale was that if you prevented the early infection with the Staph aureus, you might prevent the later infection with Pseudomonas. There's also some clinical trial evidence base to support the UK approach. The Weaver study was undertaken in the 1980s and published in 1994. That's the PubMed ID number. But this was quite a small study of 38 infants randomly allocated in a parallel design to either have flucloxacillin or antibiotics given in a more episodic or targeted manner. And so it was an open label study, and the children were followed for 2 years, which is not terribly long. But what they did demonstrate quite clearly was there was significantly less Staph aureus and less hospital admissions in the flucloxacillin group. And that was quite important evidence for UK physicians to sort of maintain their attitude towards using anti-staphylococcal prophylaxis. Contemporaneously, there was a study undertaken in the US, the Stutman study, about the same time, but published later in 2002, although reported at conferences in the early 1990s. And this is the PubMed ID number for this study. A much larger study, and a big ask really this for families. It was a placebo-controlled study, and the placebo was being compared to cefalexin, which has a slightly wider spectrum of action compared to flucloxacillin, but very good anti-staph properties. And these children were followed up for a considerable period of time, for 5 to 7 years. So a big ask for families. And that probably explains why so few really completed the study and provided data for the analysis. But what the data showed was less Staph aureus in the children who were on cefalexin, but more Pseudomonas aeruginosa, but not at the expense of reduced respiratory condition. So interesting findings, and this kind of led American physicians to move away from antibiotic prophylaxis. This has been reviewed by Alan Smith and Sarah Walters, sadly no longer with us, in their excellent Cochrane systematic review. And these are forest plots, and you're probably familiar with these, but this is looking at identification of Staph aureus on respiratory cultures, showing significantly less with prophylaxis. So that favors prophylaxis over this side. And these are all significant results at all these time points. With regard to identification of Pseudomonas, again, there's a trend towards us getting older, 6 years, a trend towards it becoming significant, but not really crossing the line unless you aggregate all these data. And then there was a significant finding of increased Pseudomonas aeruginosa. So what these data have led to is a sort of disparity across the Atlantic, really, because the current European CF guidelines suggest that antibiotic prophylaxis may be considered and may be indicated, but it talks about there being debate and a possible association with increased Pseudomonas aeruginosa infection. But it's out there and it's open, and obviously we have the UK guidelines. But in the US, the guidelines say that they recommend against the prophylactic use of oral anti-staphylococcal antibiotics. So quite a disparity, really. In reality, life is complex, and you've probably already heard, I think, in the first talk around the interesting growth in knowledge that we have around what's going on in the airways, and the fact that there are an awful lot of bacteria in the lower airways. So this is normal. This is the lung microbiome, which is being increasingly characterized and was recognized a couple of decades ago. And these bacterial groups are consistent within a person, and over time we know these things, and these bacteria are diverse and correlate poorly with what's going on in the upper airways, in the nose and the throat. It's not a lot of bacteria in the airways, but compared to, say, the gut or the skin, but it's a significant environment. And we know that people with CF who have, say, chronic airway infection with Pseudomonas or other bacteria have a reduced diversity of their microbiome. So that's what we know, but there's a lot of things that we don't know about how far these microbes go down, whether they're permanent or transient, where they've come from, and how important they are for respiratory health. But what we anticipate is that every time we give a person with CF a course of antibiotics, we're going to be disrupting this microbiome as we disrupt microbiomes everywhere in the skin or the gut. So that's quite an important factor when you're considering giving several distinct courses of antibiotics. So we embarked on the CF START study, and it's been going for nearly 5 years now, although it was over 20 years in the making, and it did evolve over time, the ideas, through considerable stakeholder engagement with funders, but also with people with CF and their families. And interestingly, the START study is powered on a safety outcome, which is unusual for a large pragmatic HTA funded trial, which are normally funded on showing that something works, an efficacy measure. And the outcome measure that is the primary outcome measure is age at first growth of Pseudomonas aeruginosa, because this was the issue around which physicians were anxious. And so we showed in a survey across the UK our families as well, because when you grow Pseudomonas, it's a big impact on your treatment burden and ultimately your quality of life. We designed it as a very low burden trial for families, and it's registry based. They really hardly know that they're in a trial, and we're comparing two strategies. So it's not, we don't present this study as flucloxacillin versus no antibiotics. We present this study as prevent and treat, which is being on flucloxacillin as prophylaxis, compared to detect and treat, which is where we're using antibiotics in a more targeted way, either for a growth of a pathogen or for symptoms. So it reassures family that the antibiotics will be used appropriately, as they are in many countries. I actually describe this study as comparing kind of a UK approach to a global approach, both in the US and in most parts of Europe. And as I say, it's a registry-based, pragmatic, randomized trial. It's got a parallel design, comparing the two strategies, and we're collecting the outcomes on the UK registry for 48 months. So it's a long study for patients to be involved in. This is the primary outcome, but we're measuring an important secondary outcome between 40 and 48 months of age. By doing a multiple breath washout test, we're measuring their lung clearance index. And this is an age where this test is more feasible. And we're doing this in a central laboratory in Great Ormond Street. Unfortunately, because of the pandemic, some of the early babies in the study have missed the opportunity to have this test, but we're now about to start doing this test on children who are coming to the end of the study. It's a registry-based study, as I say, and our registry provides tremendous data, both for research, but also for quality improvement exercises. And we had a sort of philosophy of entering data on an annual basis, but since we've started CF START study and other initiatives as well, people in the UK are getting much more used to entering on an encounter-based process, a bit similar to generally what happens in North America. And we've developed this CF START module, which sits just parallel to the registry, but it's an anonymized database that can be then interrogated by our clinical trials team. It's a truly UK-wide study, and the success of the study has depended on the enthusiasm and encouragement of many of my colleagues across the UK, who I'm very grateful to and who I buy beer for on a regular occasion whenever I see them. Fortunately, we had a pandemic, which saved me a lot of money, but it's a truly UK-wide study. Recruitment. This was what we initially anticipated the recruitment rates would be, and we didn't just pluck these numbers out the air. They were based on registry data and newborn screening program data on the number of screened infants. But this was our actual recruitment rate, and this didn't represent families refusing to be in the study. Actually, over 80% of the families approached go into the study. So that wasn't really the problem. What we identified is that we're actually seeing less babies than we anticipated, and this may be a reflection of our newborn screening program being established for over 10 years now, and people making reproductive decisions. So we're actually seeing less babies with CF, but also we were finding that a proportion of the babies who were going onto the registry being reported as CF actually didn't have CF. They had an unclear diagnosis, or what we call in Europe CF SPID. And obviously it wasn't appropriate for them to be enrolled into the study. So we evaluated our recruitment targets, and we were kindly given a funded extension to go out actually to January 2023. And as you can see on the reevaluation, we're pretty steadily recruiting between 5 and 10 babies a month, and we will continue to do so. And this line shows how many are available, and as you can see, we do recruit the vast majority of available babies. So that's a credit to my colleagues in the UK, and I'm very grateful to all the members of the multidisciplinary teams who are constantly sort of championing CF Start to families and enabling us to succeed with our recruitment rates. So what's gone well? Well, maintaining enthusiasm has been quite a challenge for such a long study that just sort of seems to be going on forever. So we're constantly communicating with our research teams. We reward landmark recruitments at 100, 200, 300, and we'll do as we move forward. It's been difficult to maintain enthusiasm and to keep a high profile, but we've managed to do that. What's been really interesting is that there's been this kind of shifting sands in the UK, and I've seen that as I talk to all my colleagues across the UK around what were some very strongly held views on antibiotic prophylaxis, and that we should use it and should not consider not using it, to now being much more in equipoise. And I think actually being involved in the CF Start study has helped us move forward as a community in that regard, and maybe also some retirements and some younger sort of colleagues coming along. So that's been fascinating. And as I mentioned, recruitment's been steady and good even during the pandemic. I mean, obviously the pandemic didn't stop babies with CF being recognised through newborn screening, and we recruited a significant number of infants during the pandemic. Also, and this is a good thing, but also a bad thing, is the primary outcome event is occurring. We know that. We don't know how much in each arm, but in an open manner, we know that we're seeing Pseudomonas, and we're seeing it at around the rate that we were anticipating. So that gives us good confidence that we're going to be able to answer the question that we have posed there. The other question is CF Start still relevant as we go into this sort of era of variant-specific therapies, modulators? And we had an investigators meeting in November 2020, and it was really interesting and heartening that colleagues across the UK felt this is a question, they want an answer to this question. They're invested in it, and they want to know the answer to this question. So we will provide them that answer. A number of outcomes are possible, and actually will be very interesting. We could have different messages from different outcomes, and we'll need to do a lot of post-study knowledge transfer to sort of then take that knowledge into clinical practice. It might affect my practice, it might affect your practice. So it will be fascinating. I think what the study has done, and I've mentioned this, is it's really brought the UK together in considering this issue and improving our evidence base. So that's been important. And finally, just to mention briefly, it's provided a robust framework for running trials, and we've just started running another trial called CF Storm, where we're using the registry, but I won't talk about that. So thank you for listening. It's been a fascinating time, and hopefully you'll invite me back when we get the result of the study. Lots of people to thank, but I just wanted to particularly thank Margaret and Claire, who sit on our oversight committees and have been absolutely tremendous and very supportive, very critical as well, and that as they should be, and that's great. And so we're very grateful to them. So thank you very much for listening. I look forward to talking to you, I hope, in a What's It session. But if you have any questions and you can't join that, don't hesitate to email me. Many of you will have my email address, but email me at any time. This is my son. When we started the study, is now a full-grown adult. Okay, take care, everybody.
Hello, I'm Margaret Rosenfeld from the University of Washington and Seattle Children's Hospital, speaking today on Pseudomonas eradication and long-term outcomes. Here are my presenter disclosures. Let's begin by reviewing the progression of Pseudomonas infection in the CF airway. It starts with initial infection, which is of low density, non-mucoid, antibiotic susceptible, and provides a window of opportunity for Pseudomonas eradication. Typically, over time, individuals develop intermittent Pseudomonas infection, in which Pseudomonas undergoes adaptation to the CF airway through biofilm formation and development of virulence factors. Inevitably, in general, though this may change in the era of highly effective modulator therapy, infection becomes chronic, at which time it's difficult or impossible to eradicate. Now, initial Pseudomonas infection is typically acquired from the environment. Pseudomonas is ubiquitous in the environment, typically in moisture areas. Abnormal mucociliary clearance, airway inflammation, structural airway damage, and impaired airway surface liquid innate immunity due to the ASL characteristics predisposed to initial acquisition in the Pseudomonas airway. And the risk is about 16% per year in infants and young children from our EPIC observational study. Here you can see age at initial Pseudomonas infection from the National CF Patient Registry through typically quarterly upper airway cultures, and the median age at acquisition is a little bit under 3 years. This, of course, differs by the population and the type of airway sampling. There are a few risk factors identified for initial Pseudomonas acquisition, but do include minimal function mutations, living in warmer, wetter climates and in rural environments, and increasing air pollution. The outcomes of initial PA infection are subtle. This has been looked at most closely in 2 studies, the EPIC observational study, which is based primarily on oropharyngeal cultures and in patients 0 to 12 years of age in enrollment, and the ARREST CF study out of Australia, in which samples, in contrast, are from the lower airway through BAL, and participants were ages 0 to 2 at enrollment, and then, at initial sampling with follow-up to age 7. In the EPIC study, we found no effect on FEV1 or weight of initial Pseudomonas infection. We did see an increased rate of pulmonary exacerbations and increased crackles on physical exam. In ARREST CF, there was indication of initial Pseudomonas infection being associated with a lower FEV1 up through age 7, but no clear effect on lung clearance index, which is a more sensitive measure of early CF lung disease, looking at regional heterogeneity of ventilation, and a clear inflammatory response. In contrast, chronic Pseudomonas infection has very clear impact on outcomes. In older studies, multiple, it's been shown to accelerate the rate of FEV1 decline, be associated with increased exacerbations, and even have an effect on survival. This is just some preliminary data from our EPIC observational study, which looked at the effect of chronic Pseudomonas infection on FEV1 decline. And you can see here in red that FEV1 decline is greater in those who are chronically infected. So this background provides a pretty clear rationale for Pseudomonas eradication. The goal is to intervene with antibiotics during this window of opportunity at the time of early infection, when the Pseudomonas are in low density and relatively sensitive to antibiotics, and there hasn't been much damage to the airway, in order to prevent chronic established infection. Eradication therapy, as we all know, is universally recommended around the world now, typically with inhaled antibiotics plus or minus oral antibiotics. On occasion, IV antibiotics are used as well. The short-term microbiologic success of Pseudomonas eradication therapies is about 75 to 90%. And this is true really across multiple different agents and combinations of agents, ranging from different inhaled agents to inhaled plus oral to IV followed by inhaled. But on the other hand, recurrence rates are also relatively high and are about a third, maybe a little bit less than a third, within 1 to 2 years. There have been studies from numerous countries that have shown a declining incidence and prevalence of Pseudomonas. This is from the CF Foundation National Patient Registry. And you can see that across all ages from 2006 to 2012, there's been a decline in the incidence and also the prevalence of Pseudomonas, likely due to some combination of better infection control measures, but also some role of Pseudomonas eradication regimens. However, I would like to point out this cautionary note from the ARREST-CF study, in which BAL samples were obtained from infancy through age 7. In this particular analysis, there were samples from 380 children, including 1789 total samples from 2000 to 2018. And eradication was accomplished, depending on the center, either with 2 weeks of IV followed by 4 weeks of inhaled therapy, or 3 months of inhaled therapy, in which the first and third month also had oral therapy. And what you can see is that over this period, there was a clear decline in Pseudomonas aeruginosa in the samples, but also an increase in Aspergillus, such that now Aspergillus is actually the most commonly isolated organism, with some concern that Aspergillus is actually a pathogen. So important to keep that in mind. On the other hand, we found more reassuring results from our EPIC study, in which we evaluated the association of cumulative exposure to antibiotics during the EPIC clinical trial, with long-term follow-up through the EPIC observational study for a mean of 5 years, and looked at subsequent risk of acquisition of drug-resistant pathogens. And we found no increased risk with inhaled antibiotics. We did find an increased risk with IV antibiotics, and that's seen here. So no increased risk of acquisition of new multi-drug resistant Pseudomonas or MRSA. Results were similar with other gram-negative pathogens, similar for oral, but we did see an increased risk with ever versus never exposure to IV antibiotics during the EPIC clinical trial period. So that is more reassuring. Now let's move to the heart of the presentation. What are the long-term outcomes associated with Pseudomonas eradication? So there really is remarkably little data here. We know very clearly about the microbiologic success of eradication regimens in the short term, but in terms of long-term follow-up, and particularly from a clinical endpoint standpoint, there has been one trial that has looked at this probably most rigorously, and that's linking the EPIC clinical trial to the EPIC observational study. So just to remind you, clinical trial participants were children less than 12 years of age who either had lifetime PA negative or had been PA negative for at least 2 years, and then had new acquisition of Pseudomonas, after which they enrolled in the clinical trial and received an initial course of inhaled anti-pseudomonal antibiotics, and then were randomized to cycled or culture-based maintenance antibiotics therapy over an 18-month period. And if in the last 12 months, they had no further isolation of Pseudomonas aeruginosa, they were labeled as sustained eradicators. If they had at least one PA positive culture in that list last year, they were labeled as non-sustained eradicators. And then these individuals were followed up for 5 years in the EPIC observational study. This work was led by Dr. Nicole Hamblett Here's what we found. So from a microbiologic standpoint, those who were sustained eradicators were much less likely to develop chronic Pseudomonas than those who were non-sustained eradicators. And also, sustained eradicators had much later and acquisition of Pseudomonas aeruginosa for a second time, and also this was delayed. So 60% of the sustained eradicators during the following 5 years had another PA positive culture, as opposed to 84% of those who were non-sustained eradicators. And the median time to next isolation was 3.5 years in the sustained eradicators, compared to 1 year in the non-sustained eradicators. So clearly, important effect of Pseudomonas eradication on long-term avoidance of recurrence of Pseudomonas. However, we were unable to detect an effect of sustained eradication on either lung function or subsequent exacerbations. So why might there have been this lack of effect on clinical outcomes? Well, participants were overall young and with well-preserved lung function. So at enrollment, they had a mean age of 7.2 years with solidly normal lung function, and a mean annual FEV1 decline of only 0.1% predicted, which is much less than in the registry as a whole, and clearly would make it harder to detect a long-term treatment effect. Also, they had a very low conversion to mucoid Pseudomonas, which has been shown in other studies to be more associated with clear changes in clinical outcomes, including about less than 30% over 5 years of follow-up. And also, those who were non-sustained eradicators did receive more antibiotics during the follow-up, which may have mitigated the effect of recurrent Pseudomonas. 2 other studies have looked at the effect of Pseudomonas aeruginosa on long-term outcomes. These were both Canadian studies. In Toronto, in a retrospective study among 116 patients who were categorized as never acquiring Pseudomonas, having Pseudomonas successfully eradicated, or having persistent Pseudomonas, there was no difference in FEV1 decline between the groups. In Ottawa, as part of a secondary analysis of a 3-year prospective study of adults, there was no difference in FEV1 between those who cleared Pseudomonas and those who were persistently infected. So why do some patients fail to eradicate? Well, in terms of host factors, we have also identified minimal function genotype as a risk factor, and inflammation clearly plays a role. Positive Pseudomonas serology at the time of an eradication attempt is associated with less likelihood of eradication. And interestingly, from our SCF, the BAL neutrophil elastase levels following eradication predicted the risk of Pseudomonas recurrence at 1 year. There are also pathogen factors, mucoidy, and then other phenotypes representing chronic adaptation have been showed to be associated with failure to eradicate. Also, epidemic strains are more difficult to eradicate. The treatment factors are also very important. These are some potentially more modifiable. So effective drug delivery and distribution is required for effective eradication. So when we're prescribing inhaled medications to our very young patients, we need to really help the families understand how to deliver drug effectively. If the mask is only vaguely near the face or the baby is kicking and screaming, they're not going to get any drug into the lower airway. Also, delays in detection of Pseudomonas and treatment initiation are associated with less likelihood of eradication. And our limitations in monitoring the effective treatment may delay a second attempt at eradication. So in summary, Pseudomonas eradication is associated with delayed chronic infection, but the effect on clinical outcomes is less clear at this point. The incidence and prevalence of Pseudomonas are decreasing, likely in part due to Pseudomonas eradication regimens, in concert probably with newborn screening, more effective infection control, and other reasons. We do need to be concerned about antimicrobial stewardship and the risk of promoting resistant organisms, even though the data are somewhat conflicting. And finally, what are the next steps? How can we improve the success of Pseudomonas eradication? Well, first of all, eradication success rates initially are quite high, but there's still about a 20% failure rate and about a 30% recurrence rate over 1 to 2 years. So we may need personalized approaches based on risk factor profiles. There's also emerging evidence that initial Pseudomonas isolates may have phenotypes of chronic infection. Does this mean we need more sensitive methods for early detection of Pseudomonas so we can treat earlier? And how will highly effective modulator therapy affect our detection? So if patients are less likely to expect rate and even come in for decreased visits, how will that affect our earlier detection of Pseudomonas? And then lastly, despite the eradication of Pseudomonas, we still do see bronchiectasis, air trapping, and abnormal lung function. So Pseudomonas is not the only bad actor. Is this due to inflammation? What is the role of other members of the microbial environment? And then again, how will highly effective modulator therapy affect the risk of Pseudomonas and of disease progression? With that, I'd like to end by acknowledging the EPIC investigators all around the United States, the patients and families who enrolled in the EPIC studies, the CF Foundation for their tireless support of the EPIC studies, and the CF Foundation National Patient Registry. Thank you very much.
Hello, everyone. Thank you very much for attending today, and thanks to the organizers for inviting me. I do not have any important disclosures for this presentation, relevant ones. This is a graph that many of us use to kick off any discussion about CF respiratory microbiology. It's included in the CFF patient registry report every year. This is for the year 2019. And it just gives us a good framework to start these talks. It shows you the proportion of people in the US for that year who are culture positive for all of these traditional pathogens. And I put this here to highlight the microbiology of children with CF, at least in the US, particularly in relation to these traditional pathogens, Staphylococcus aureus, which is very common, and its subtype MRSA, Pseudomonas, and here's Haemophilus. I'll talk about all of these a little bit. Now, there's another way that the foundation gives us to look at these dynamics according to age for a single year. And here are the children again. This is a really interesting graph that shows you the proportion of patients who had different culture types, not just individual organisms, but those cultures in which only one organism was detected. Here's Pseudomonas in green, Staph in dark blue, Haemophilus in light purple. And those patients in whom the cultures revealed multiple organisms. We call this polymicrobial. That's a pretty large fraction of children. And another group are the children in orange and in gray here who didn't have any significant pathogens detected by culture. And I'll come back to these in a minute because these are important groups. The foundation also allows us to look at the change in microbial ecology over the past 2 decades. Not just for 1 year, although these results are not broken down by age. You can get the idea from this. It's shown us that the proportion of patients who are culture positive for Staph has gone up over the past couple of decades, including MRSA subtype, and Pseudomonas detection has gone down in prevalence among the entire CF population. This is true for kids as well. This has been really nicely described, I think, by a couple of studies led by Lisa Saman and others. Their first study on this was published in between 95 and 2005, examined the period between 95 and 2005 from the registry. And I just wanted to highlight how the prevalence of Pseudomonas was already decreasing in this 10-year era among the 11 to 17 group. These are children, of course. And the same group showed us that in the subsequent 4 years or 5 years, between 2006 and 2012, that trend continued. And it also continued in a number of adults, as you can see up here. So in considering whether this change in ecology will continue or magnify or be different in the post-modulator era, particularly among children, it's important to consider that microbial ecology was already changing before modulators, that it changes throughout childhood and individual people, that from what we know from adults, as I'll show you in a minute, that this ecology is likely to change even more after modulators. and that modulators might also change our ability to sample and measure this respiratory microbiology. So a little bit about what I mean regarding that. There are really three common sample types for respiratory microbiology in people with CF, and here they are. Among these, we prefer sputum because it nicely balances convenience and lack of invasiveness with yield, we think, for lower respiratory tract microbes. But increasingly, we're unable to get sputum, particularly from children who, under the age of 6, rarely expectorate anyway, and they're expectorating a lot less these days, thankfully. Although a number of investigators have shown us we can sometimes induce sputum production even from children. Adults are also expectorating less, and this trend, we're told, was occurring even before CFTR modulators, and luckily, thankfully, is continuing after modulators. Bronchoscopy and BAL obtaining is not routinely done in a lot of places, and it's controversial whether it's useful for diagnosing or surveying for infection or driving therapy. And these issues of detection have very important implications for how we're diagnosing CF infections and how we will in the post-modulator era. And in fact, swabs, topical swabs, are the standard of care for most children. There are two different types. We generally do oropharyngeal swabs in the United States. In Europe, in a lot of places, an induced cough before swabbing is the standard. That's a cough swab. They're both easy. They give similar results. They both have variable and imperfect sensitivity and specificity relative to the other sample types we think are better, like lavage or sputum. And this sensitivity and specificity are really best studied for Pseudomonas aeruginosa. But regardless, whether what was found regarding this utility before modulators, whether that will be true in the post-modulator era has really not been studied. So as an example, one of my favorite studies of the utility of OP swabs, which was done well before the modulator era, was by Margaret Rosenfeld and others. And she and the investigators compared sensitivity and specificity in children with concurrent or very recent BAL. And I don't want to go into detail, but the point is that sensitivity and specificity for Pseudomonas, as well as Haemophilus and Staph aureus, are variable and not perfect. And again, whether these numbers will reflect what happens in the context of modulators has not yet been defined. Another caveat that's important to consider is not just sampling, but also what we do with those samples when they get to the CF lab, the microbiology lab. And standard detection methods involve cultures, which are quite selective. They are highly refined, they're very reproducible, and they're well validated. But they can miss potential pathogens. We know that. We also know they don't always identify pathogens or what is the pathogen or pathogens that are making somebody sick at any particular time. And the most dramatic and I think influential example of that came from Edith Zemanek and colleagues in 2010 when they showed us in a single center study a very large fraction of samples from children admitted to the hospital at the single center with an exacerbation that did improve with antibiotics were completely culture negative for traditional pathogens. So these were the reasons why I think a lot of us started to explore sequencing-based or DNA-based methods, microbiome methods, or microbiota methods, which have proven to be really useful, particularly for population-level microbiological analyses. And I don't want to go into detail on results. Again, just give you a couple examples of how microbiota methods have been really useful for population-level studies of oropharyngeal swabs, here from a British group, showing on average, a finding that's been made in a number of studies, an average increase in OP swab microbial diversity over the first couple of years of life, that is in infancy. And similarly, studies using BAL in young children, this is from the Arrest CF group in Australia, Freeman et al., showed us the utility of population level analyses of BAL as well. Now, what we're seeing here is an average decrease in microbial diversity in this population of children in BAL over the first 7 years of life. So in summary of these caveats and asides, pediatric respiratory microbiology has been changing for a long time. The sensitivity of our detection methods have always been variable and imperfect. Swabs of the oropharynx are increasingly being used as people with CF expectorate less, and they're really used often in children. And whether these methods are going to be useful in the context of modulators remains to be studied, but it really needs to be defined because they remain the standard of care for most people with CF throughout the world. And DNA-based microbiome methods are growing in use, particularly for population-level microbiological dynamics, but their utility in clinical, their clinical utility has yet to be really well established. Okay, so with that background aside, or behind us, I would like to thank these investigators, this German group, for publishing this very recent review on the topic I'm supposed to be talking about today, with a title that's remarkably similar to the title of my talk. Thank you. It made putting these slides together very easy. However, as this review on this topic really points out, most of the studies and most of the participants in these studies that it discusses were adults, not children. And most of these studies were of a single modulator, which of course was the first to be approved, that's ivacaftor. So generalizability has not been established yet to other modulators and to children, which is really the topic of this talk. And I apologize for the size of the text here. The point of this table that came from this review that I showed you is just to show you how many studies there are out there and a few similarities and differences. For example, these green circles show you the number of studies that included children. None of them focused on children, but they included them. So that is helpful and hopeful that the findings that these studies made might be applicable to children. And I want to focus on one study first, because it made a finding really carefully and with a lot of granularity that was made in some of these other studies. And this was a study by Helche et al. In 2015 in Clinical Infectious Diseases, really scrutinizing the culture-based data from the GOAL study, which is described in this row population 2014. And this study really focused on Pseudomonas aeruginosa detection. And so in this study, the group found that something that was found in a number of other studies, which is that the prevalence of culture positivity or detection of Pseudomonas decreased, as you can see here. This is percent of patients with each of these organisms in the 2 years before ivacaftor, in the 1 year before ivacaftor, and in the year after ivacaftor. Pseudomonas detection really decreased in the year afterwards, including this subtype of Pseudomonas, mucoid Pseudomonas, significantly, and that was not true for other organisms. So this has, again, been found in other studies, and other studies have also extended this finding to show that the culture abundance of Pseudomonas tends to go down, that the relative abundance of Pseudomonas in sputum tends to go down when you're using sequencing or PCR methods, at least initially. And I'll come back to what I mean by that in a minute. And this study is a very recent publication by the same study group, examining, again, this is the GOAL study group, examining data for now up to 5.5 years, showing that there does appear to be a sustained effect in relation to detection of Pseudomonas. This is not abundance, just presence or absence. So the odds ratio of having Pseudomonas in the 5.5 years after starting ivacaftor is relatively low compared to before. So that appears to be a sustained effect. And in blue circles or blue squares here, I'm showing you all of the studies that made similar kinds of findings in relation to Pseudomonas aeruginosa in particular. And I wanted to focus on another one that didn't make this list because the study design was a little bit different, by Anthony Fisher and others, published in 2019, where their outcome of interest wasn't just Pseudomonas detection, but rather detection of Pseudomonas or any type of Staph aureus, which they lumped together as infection, a very interesting outcome. And then they looked at single-center data in 2 different eras, in the pre-modulator era, the 4 or 5 years before any modulator was approved, and in the 5 years after both ivacaftor and ivacaftor lumacaftor were approved, 2012 to 2016, and compared the detection of infection in that single center population, CF population, in those two eras, before and after modulators, among people who never started on modulators versus the people who did start on modulators. And these are our survival curves showing you the proportion of patients who had new infection, and they were similar among those who didn't start on modulators in the two eras, whereas in the era when after modulators and people who did start on modulators or were eligible for them, there was certainly a decrease in the proportion of patients who met their infection criteria. So again, similar in this very different population with this different outcome. I also wanted to focus on another study here, very recent, from a German group, because it included not just microbiota outcomes, but it really focused on a different modulator. It's the only study in this list that focused on ivacaftor, lumacaftor. And in this study, they made a finding that was very similar to findings made with ivacaftor in other sputum microbiota analyses, which is that on average, sputum bacterial load, here by quantitative PCR, tended to decrease in this large population after starting on lumacaftor, ivacaftor. And sputum microbial diversity increased on average by a significant amount on average in this population. So again, you can see the individual data and see how it varies quite so much, but this also highlights how useful these kinds of measures and studies can be on a population level. So, and again, these findings were made in a number of different modulator-focused, ivacaftor-focused studies. But before we draw any conclusions from these and other findings, here's a cautionary tale that's very important to consider from an Australian group, a multidisciplinary Australian group in 2018, where the title of the paper says everything I wanted to communicate. And that's that there's a lot of variation between people with CF in terms of their baseline microbiota that makes it really hard to find differences on starting ivacaftor. But even more importantly, the effect of antibiotics and other co-therapies, such as perhaps airway clearance, who knows, they can have a pretty dramatic effect and be an important confounder. And because these therapies might change after starting on modulators in terms of frequency. So it's important to consider confounders before we assume the modulators are the reasons for the changes we observe. Okay, so the most common findings, to summarize what studies have found in general on this topic, the most common findings are that culture conversion from Pseudomonas positive to negative with modulators was most likely in people who did not have persistent Pseudomonas infection before modulators. That is, if they had intermittent detection or infection before modulators, they were most likely to become culture negative after modulators. Overall sputum microbial diversity tended to increase on average, not universally, not in every study, but this was a general finding. And total bacterial load tends to decrease in sputum. And Pseudomonas culture density did tend to decrease in many of these modulator studies. This, by the way, these are results from a study I participated in, led by Pradeep Singh, the HICERT study of people with the G551D mutation starting ivacaftor in Dublin. And what we found was an average decrease in culture sputum density of Pseudomonas in the first year after starting ivacaftor, but then an average increase again after a year of starting ivacaftor. And this is a finding that's been made in at least a couple of studies of unclear clinical significance. For example, here is a study, again, that was too recent to make that table that I showed you, from a group in Amsterdam, the United States, that used a multi-omics approach to study what happens in sputum after starting on lumacaftor, ivacaftor in this case. And they found relatively small changes in the overall sputum microbiome, but they did find initial changes on average in Pseudomonas density by metagenomics that was followed by a rebound, an increase again in Pseudomonas on average in the study population. A couple of other important findings that are important to consider for future studies. They also found a disconnect between the metabolome, the small molecules that were found, the complex molecules that were found in the breath, as compared to microbiology. The dynamics of the two did not track together. There were long-term changes in the metabolome that may have something to do with inflammation. And importantly, several of their subjects just stopped expectorating, which made it hard to draw general conclusions because the participants who were studied at the end of the study were those who continued to expectorate and may not be representative of the others. So what have we learned at this point? The microbiology of the CF airway is often changed by modulators. Some of those effects don't appear to be sustained in adults. The effects are not so easy to disentangle from those of other treatments, particularly antibiotics. And whether these results will be observed in children is not yet clear. But ongoing studies offer us a really good opportunity to study this. Some exciting new observational studies that allow us to study whether modulators can prevent the acquisition of new pathogens or the onset or progression of lung disease. And interestingly, we'll be able to study the relationship between the dynamics of lung disease and microbiology in a way we haven't before. But it's not clear yet how we can best study this without sputum. And these are these two ongoing groups of studies, the PROMISE study in people with CF older than 6, and the BEGIN study in young children with CF. And in these studies, we're examining respiratory microbiology and concurrent measures of lung disease. So watch this space. With that, I'd like to thank many people, particularly my lab for helping me, the foundation for funding our studies, Dr. Rosenfeld for inviting me, as well as going through these slides, and of course, our patients and families, and you for participating. Thank you.
Well, thank you. I think that we've now live. I'd like to introduce myself, Sarah Ranganathan. I'm one of the moderators here, and I'll hand over in a second to Professor Margaret Rosenfeld, one of the speakers and moderators. After first thanking our 4 great speakers, just a reminder, we've had a conversation about the early airway infection in the microbial community from Catherine Freeman, a discussion around the controversies in anti-staphylococcal prophylaxis from Professor Kevin Southern. And then Professor Margaret Rosenfeld talked about Pseudomonas eradication and the long-term outcomes in relation to Pseudomonas infection. And then finally, another excellent talk from Lucas Hoffman, who talked about early infection in the era of CFTR modulators. We've had enormous numbers of questions in the chat, some really fantastic questions. And I may start by asking the first one, and then I'll hand over to Margaret to continue with some of the questions of our great panelists. The first question I wanted to ask was directly to Catherine Freeman. In your talk about the microbiome, you also showed the longer term outcomes in relation to Staph aureus, that when there was infection early on in life, there didn't appear to be a difference at 25 years in terms of the longer term outcomes in lung function and survival. And there's a question from JP Clancy, who's asked, was there a differential impact of early sensitive Staph aureus compared with MRSA or MRSA Staph aureus on 25-year outcomes?
Thank you, Sarah, and thank you for that question, JP Clancy. I must say that in Australia, the overall prevalence of MRSA is very low. I believe it's about 4% in the general population at the moment. And in the early 90s, when these BAL were collected, it was even lower. So I actually don't think we had any infants in this study with MRSA infection, but I would be very keen to see the outcome of that analysis in a different population.
And I think what I might hand over to you, Margaret. No, go ahead.
You can tell this actually is live. And I also would additionally like to thank Sarah and Catherine for being up at dark 100 to be on this call across so many time zones. So thank you very much. Catherine, you gave an absolutely outstanding presentation, as did the other speakers, but I think yours may have generated the most questions. So I'll ask a few more of you on behalf of some of the audience, and then have some time also for questions that many panelists may want to jump in on. So Dave Nichols here, a colleague of mine and at the TDN, asks, the long-term outcomes data on Pseudomonas density is very interesting. Did lower colony forming unit density associate with intermittent or transient culture positivity?
I think that's a really good question, and one I would like to look at in more detail, and I think we have the data to do that. But the data I've presented looked at the highest ever density of Pseudomonas in that patient in the first 5 years of life on BAL. So unfortunately, I can't answer that question, but I look forward to doing that analysis.
Great, thank you. Another question for you is, did those children on prophylaxis with a lower Shannon diversity index and decreased neutrophil elastase have less exacerbations compared to the US patients who were not on prophylaxis?
That is a fantastic question. And I think in the time of the study period, so that was an SCF study conducted prospectively and published only a couple of years ago. So at the time that the analysis was done, the Australian infants had a median age of about 3 months and the American infants had a median age of about 6 months. So in that first time in the first few months of life, no, I don't think there was a difference in exacerbation rate, but it would be good to then be able to look at that group prospectively, I think.
Thank you. And then Dr. Pradeep Singh asks, well, first he says, very interesting talk. Thank you. Do you know what drove the decrease in alpha diversity that correlated with inflammation? Was this decrease a consequence of the appearance of traditional CF pathogens, or did the absolute abundance of non-traditional organisms also show changes?
I think that it was actually the appearance of the traditional CF pathogens. And so what we saw repeatedly was that when you had infection with Staphylococcus, when you had infection with Pseudomonas, the abundance of that just dominated, became very, very much dominant in those samples. And I didn't present the data, but we looked at whether you had a dominant pro-inflammatory pathogen, which were really the typical CF pathogens, and similarly dominance of those pathogens without taking into account diversity was also associated with inflammation. So I think it is the onset of infection with a CF pathogen that changes the diversity and then the diversity metrics, and then is associated with inflammation as well.
Great. And now let me ask a question of the panel at large, which is one I think we're all interested in. What are the implications for clinical care from our increasing understanding of the early microbiome, both the lung and the gut? And I might add also what's known about changes associated with utilization of highly effective modulator therapy. Or I guess another way of asking that is, do we think there's going to come a point when we might use the microbiome or non-cultural methods in routine clinical care, and how?
Do we think the airway microbiome has a role, Margaret? I mean, obviously in the gut, you can really get your head around it, a number of physiological roles for the gut microbiome. It's massive and it's important. But it's the airway microbiome. I still can't really get my head around that it has a role, that it's important physiologically in the airway. I think it just happens. It's something that's there. Or what do you think, Catherine? Do you think it has a role, a protective role, or a
It's a really, is it just there, and is it different in CF and as the inflammation because of the organisms that we've always known to be there? I think it's very clearly different in CF and very clearly different from the beginning, even in children without airway inflammation and without evidence of, clinical evidence of lung disease. But I think we need to do the metabolomics and then understand the differences that different particular bacteria and different combinations of bacteria and the host pathogen interactions cause to answer that question properly. I suspect over the next number of years, and I'd be interested in Luke's response to this, but I think over the next number of years we'll understand that question a whole lot more.
In children without CF, the data we have is mainly cross-sectional. We don't have much longitudinal data, but the small amount of data I understand, it shows consistency over time, which is interesting. And I wonder if we should be aiming to try for consistency in children with CF, and how's the best way to achieve that. So my thoughts on prophylaxis has changed a lot, and I am in equipoise because I'm kind of running the CF START study. So Margaret knows I have to be in equipoise, but I kind of was a big antibiotic advocate back in the day, and then I became quite the opposite, really. I was more thinking that this is something that we have to show doesn't work and we need to stop it. But now I'm beginning to think, well, maybe if they're on an antibiotic and they're getting what we showed in the Weaver study, and there was some evidence in the Stutman study, is if you're on prophylaxis, you have less additional courses of antibiotics. If you're not on a prophylaxis, then you're more likely to be given broad spectrum cephalosporins, amoxicillin, coamoxiclav, these pretty potent oral antibiotics that I would think are going to disrupt a normal airway. They certainly disrupt the gut microbiome, we know, don't we? So I don't know what would be the best way forward of maintaining a good airway microbiome, if maintaining a good airway microbiome is important, which I kind of think we're beginning to feel is.
And
sorry, that's a ramble, wasn't it?
Just to throw in one other wrench in the question is around inflammation, right? So Catherine, the results that you presented where staph prophylaxis resulted in a less diverse microbiome, which is presumably bad, also was associated with less inflammation, which is presumably good. So how do we balance those things as well?
Yes, I agree, Margaret. I think it's really interesting when you look at that study, and even in spite of that, we've chosen to stop antibiotic prophylaxis, arguing that if there's no long-term detriment to having staph infection treated symptomatically, then should we be disrupting the microbiome? But then more than disrupting the microbiome, should we be the airway microbiome? We're disrupting the gut microbiome and all of the potential adverse effects and the cost and the treatment burden and all of those other aspects of antibiotics that we often don't talk about in this forum, but that the patients I think really do care about a lot. I think that we need to understand a whole lot more about the metabolomics and the functional aspects of the microbiome itself, and I think that comes back to Kevin's first point. And then there's the gut microbiome, which I guess we are, when we're giving babies oral antibiotics, we're, I'm sure, interrupting both the airway microbiome and the gut microbiome for good or for bad.
Just a comment.
I don't think we've got time to talk about the gut at the moment. but then that comes back to Margaret's really interesting comment about arrest CF, where and if I'm right, and correct me if I'm wrong, but I don't think it was the initial neutrophil elastase level, inflammatory level, that correlated with subsequent growth of Pseudomonas. It was the one taken 3 months later. So it's 3 months after the eradication therapy for the Pseudomonas had started. And then they found the infants then who had a high neutrophil elastase level on the BAL were more likely to get a recurrence of the Pseudomonas later on. I think that's really fascinating and very sort of, to me, is quite, I feel it's possibly quite important clinically. And yet we would never do a bronchoscopy 3 months after starting eradication therapy. I don't think we would, not in a infant. What do you think, Margaret, around that? Because it kind of comes back into your inflammatory. Is inflammation there quite important, connecting that with the microbiome?
Yeah, well, I think that I'm looking forward to what Luke has to say. I think that the role of inflammation in disease progression independent of infection is critical and probably underappreciated. We also, as we do non-invasive specimen collection, don't have access to that information. So that's going to lead into one of my future questions. But Luke, I'd love to hear what you think about the microbiome and whether assessing it might be part of clinical care in the future.
I have, thank you. And I agree with everything that Catherine and Kevin just said, and Sarah and Margaret. I'm trying to collect my thoughts in a way that's going to be organized, because I feel like there are many questions that are sort of inherent in the discussion we've had. I'll talk about the GI tract at the end, at least my thoughts about the GI tract. And I'll start with thinking about my thoughts about what Kevin and Catherine were just talking about, and Margaret, the relationship between inflammation and microbiology and changes in microbiology and lung disease, which is, I think, still at this point in history, despite everything that we've heard, it's still hopelessly confounded with antibiotic treatment. And I think that a lot of the ongoing studies that we have are going to be able to answer that better. But basically, the problem is that I see is that one simple explanation for a lot of observations is that sick children or sick people get more antibiotics, and that can change the microbiology. Alternatively, microbiology might drive worsening disease and inflammation, which is affected by antibiotics, and antibiotics lead to improvement. And both of those are possible. And observational studies make it very hard to disentangle them. I would feel a lot better about making assumptions about these relationships if animal models, if pigs and mice and ferrets got Pseudomonas infection, and so that we could study these relationships a little bit more carefully, but it's not a common occurrence. And so I have decided to remain somewhat agnostic about what is driving what, because I'm really interested in the studies that that Kevin is doing, the data that Catherine is showing us, but also I feel that one of the best opportunities, or the most promising approaches to trying to disentangle these relationships is to see what happens with intervention like modulators. We may not need to study it anymore, one can hope, but we also might be able to learn a lot better what these relationships are as you sort of perturb everything. And with regards to using non-culture based methods in the future for clinical care, you heard what I said. I think the point I tried to make in my talk is I feel that sequencing based methods are really useful have proven really useful for population level studies for sort of pathophysiology and dynamics. I don't feel we're at the place yet where we can just initiate using DNA-based methods in the clinical laboratory. That's going to take a long time for a lot of reasons. One is simply practical. It just takes a long time to validate a lot of these measures and use them. Use them in a busy clinical laboratory. And to make sure that everybody uses the same methods. But I do feel like, just watching what happened with virology, clinical virology in the past, that molecular bacteriology is likely to come. We're going to have a significant problem with translating those methods to try to find some replacement for susceptibility testing, which is a commonly used method in the clinical laboratory. But the culture-based susceptibility testing is of questionable value, so I'm not sure that's important. And the other problem is distinguishing live and dead cells, which is probably important. But I do, again, as I said in my talk, I feel that culture-based methods do have limited detection or limited sensitivity for a number of organisms. And one that we study in my laboratory are small colony variant staph, for example, which at least are common in the United States and some other countries. And that's just possibly the tip of the iceberg. There may be other organisms that we're really not detecting well. And non-tuberculous mycobacteria, of course, are another example of really fastidious organisms. Haemophilus are not perfectly detectable by our detection or by culture. So I do think it's likely to happen. They're convenient, they're fast, and these kinds of methods are slowly replacing culture-based methods. But at least in the short term, I think there are going to have to be some studies to validate them. With regards to the GI tract, well, let me think. What was the question again about the GI tract? Really, so that I don't go off on a bit too big a tangent.
No, I think there would be, the main one was about the effect of modulators on the gut microbiome.
Yeah, that's a topic of of ongoing studies. There have only been a couple of studies, a really nice one from Australia, a very small one from our laboratory, that have looked at the effects of modulators on the GI microbiome. And there does appear to be a similar kind, an effect. There is a fairly well described GI dysbiosis in at least in young children who've not yet had antibiotics. who have CF compared to similarly aged kids who don't. The clinical or pathophysiologic consequences of that dysbiosis are still, again, being nailed down, but there are at least clinical correlates. It does appear to correlate with measures of disease. And again, the studies with modulators are really just beginning, but it does appear that they may be able to edge GI microbiology more towards a healthy configuration, and whether that will correlate with changes in clinical outcomes, it remains to be seen. It's still early days, I would say.
I account for the enormous weight gain that we're seeing in some of the young children who go onto the modulators, I guess.
I'll just comment on that, Kevin. It may be of interest because it does come back to one of the things you raised as to if you were to use intermittent antibiotics, whether that might have a more profound impact on the microbiome. When this is from the study that Catherine presented, where we recruited children in the US and also in Australia, where we were using prophylaxis at the time, and in the US they were just using antibiotics for exacerbations. And there was much less diversity in the lung microbiome in the Australian children compared with the US children. So it sort of suggested that it was the protracted prophylaxis that had the most profound impact rather than a couple of week courses of antibiotics. And interestingly, coming on to your comment there, the children in Australia, the infants in Australia had less inflammation in their lung, but they were much bigger. Their weight was greater. And our subsequent work has shown that the microbiome in the gut was more profoundly impacted in those children in Australia as well. And what we're really looking to look at now is that are those bacteria in the microbiome impacted by prophylaxis, are they much more likely to harbor genes that confer antimicrobial resistance? We think that will be the case. And certainly if you look at some of the organisms, we've just recently published a specific study on Haemophilus influenza and Haemophilus parainfluenza, high rates of antimicrobial resistance genes, and lots that are transferred via, we presume, mobile elements such as phages, etc. So there are these very significant, potentially profound impacts of antibiotic prophylaxis beyond the clinical benefits that might accrue that I think we don't understand. And coming back to your comment there, Luke, about the gut microbiome, if we were trying to manipulate the lung microbiome, probably the best route to do that might be through the gut. And maybe, Catherine, you might want to comment on the gut-lung axis, which we know has a part to play in asthma and other airway diseases and atopic diseases. What is the potential role for the gut-lung axis in CF?
Yes, I mean, I think the gut-lung axis is where we need to be looking and where we are looking, and hopefully we'll have some data on that in the not too distant future. But I think there is a lot of potential that it's the gut, that the gut then modulates the gut microbiome, then modulates the pulmonary immune response. And so in manipulating the gut microbiome, either intentionally or unintentionally with our respiratory targeted antibiotics, we are potentially then influencing the immune response rather than the direct microbial composition within the lungs. And I think there's just so much that we don't understand that I think we need to understand to be able to answer these questions properly. But then coming back full circle, I think when we understand this, our clinical practices are likely to change even further. And then there's always the possibility that we'll be able to manipulate the gut microbiome intentionally with the aim of improving the airway, either the airway inflammatory milieu or the airway microbiome. And we could potentially be looking at using probiotics for that reason. But lots of areas of further study, I think, Sarah.
Catherine, I think that's a really interesting direction, and I agree with everything you said. The effects of antibiotics do seem to be, at least in the few studies that have been done on the GI microbiome, the effects of antibiotics seem to be more potent in some cases than modulators themselves, and so clearly they have a fairly profound effect. But I haven't been quite as impressed at the durable effects or even the magnitude of effects of probiotics to date in the studies that have been done. And so in the future, we're going to have to talk about what we mean with respect to when we say modulation of the GI microbiome. We don't have a big toolbox yet. Diet and antibiotics seem to be the biggest ones, and I suspect that diet and prebiotics may be more effective, but we have a lot of work to do to figure out exactly if we talk about modulating, what are we going to do? And I just wanted to call out that I think some of the really landmark work, or the really convincing work that's been done in the gut-lung axis, at least in CF, was done by George O'Toole and Juliet Madon at Dartmouth. Their work really supports the model that you're talking about, I think.
Thank you. Okay, I'm going to shift gears just a little bit and ask Kevin a question. Do you feel that there are differences in the pros and cons of prophylaxis when comparing different antibiotics, flucloxacillin, cephalexin, cotrimoxazole, et cetera?
Absolutely, I do, Margaret. I think the flucloxacillin obviously has a very narrow spectrum of action. We see, similar to Catherine, very little MRSA in our total CF population in the UK. So I think choice of antibiotics is really important, and I think it's something that we will try and unpick with our study results, but I think it will be difficult. There's so many problems comparing across the country, so I'm quite interested now, Catherine, with what you're actually doing in Australia with regard to surveillance, now that you're not using prophylaxis, and would, if you did isolate Staph aureus, a sensitive Staph aureus, in an asymptomatic child, would you follow the American model and not treat that, or more the European model where they would be inclined to treat it?
So what we have done is gone back to the model that we were using in the 1990s, which is, so their children are still having surveillance bronchoscopies. Many, if not almost all, are enrolled in ARREST-CF, so they have annual bronchoscopies. And obviously in the symptomatic child we treat, and we target treatment towards what we know to be their microbiology. In the asymptomatic child with a positive cough swab for Staphylococcus or for Haemophilus, we're not treating, but if we find Pseudomonas in a cough swab, we are treating and going through our standard eradication regime. And then if they have a lower airway sample, or if they have any bacteria on culture in a lower airway sample, we're treating for 2 weeks with an appropriately targeted antibiotic. And so we've moved again, where possible, back to flucloxacillin and away from Augmentin, so amoxiclav, for children that only have Staphylococcus. So we're trying to be as targeted as possible, but we are treating for lower airway Staphylococcus.
That's really interesting. And Margaret, in the US, there is some variance, but generally speaking, oral pharyngeal suction is used as a proxy for lower airway infection. Is that fair? And you would not treat an asymptomatic child who grew Staph aureus, or?
Yes, I would nuance that just a little bit. So
Sorry.
in pre or non-expectorating patients, we do rely on oropharyngeal swabs. We all agree it's not a good proxy for the lower airway, but we are reluctant to use something more invasive, such as BAL, in the absence of evidence that it changes outcomes, which will lead me to my next question when we're done with this one. But we do not tend to treat. It's similar to Australia, actually. So we do not treat MSSA isolated on oropharyngeal swabs routinely. If we isolate MSSA and then a patient goes on to have an exacerbation, then we'll treat MSSA. Pseudomonas is definitely treated, and MRSA is more controversial. So some people will treat and some people won't treat.
That's really interesting. Now, and I was very interested in your talk, Margaret. It's made me think a lot. And I'm a bit worried about our primary outcome measure is age at first growth of Pseudomonas. And I think that is an important outcome. It's an important outcome for families. But when we designed the study, I felt more confident that outcome correlated well to chronic, then subsequent chronic infection with Pseudomonas. But we don't see much chronic infection with Pseudomonas anymore, because of our successful eradication regimens, and the data that are now emerging over the last 5 years are beginning to make me wonder whether this is a good surrogate for chronic airway infection. What do you think about that?
Well, first of all, I feel silly saying this, but you devise it as a safety outcome, right? So
Yeah.
not necessarily for the link to chronic. I think that there's a relatively weak association between age at initial infection and time to chronic Pseudomonas. We showed that in a study where Sonia Helchi is the first author using the CF registry. I think that one kind of pathophysiologic mechanism would be that first isolation of Pseudomonas is a little bit more of a stochastic event since it's so ubiquitous in the environment, though we do know that patients with minimal function disease are more likely to acquire it earlier, not too much else as risk factors. But then there's probably more of a kind of chronic host pathogen interaction that determines chronic Pseudomonas infection. So that may be why the link isn't so tight.
And now, following your presentation and with the data you're presenting and your thoughts on arrest CF and so forth, do you feel that there's a need to investigate whether an anti-inflammatory, a sort of combined eradication protocol would be, whether we combine anti-inflammatory agents, whether that be ibuprofen or steroids, with the antimicrobials? Is that something that we should be exploring, or?
Well, I think that's an absolutely fascinating question. Those of us which are all of us on this call that have done work in the space of Pseudomonas eradication, are wondering what next. Should there be adjunctive modalities? And that's never been well studied. And either anti-inflammatories or maybe agents that boost mucociliary clearance would be important. The problem with the latter is that most patients are already on those, though maybe not able to use them as regularly as we would like. And the anti-inflammatories, that whole field is so loaded with challenges in obtaining correct serum levels for ibuprofen with adverse effects. So I think it's a difficult area to study, particularly since the median age at first acquisition with using OP swabs is little tiny kids. They're under 3 years of age. But I don't want to monopolize the conversation. Would love to hear other people's thoughts as well.
Luke, yeah.
Again, Kevin keeps stimulating me to want to respond about something, and you brought up the topic there of bronchoscopy, and we're aware from Claire Wainwright's study many years ago in JAMA that the BAL-directed therapy provided no significant advantage over non-BAL-directed therapy using airway swabs in detecting and treating and eradicating Pseudomonas. But one of the provisos that we continued to do bronchoscopies in early life was that we wanted to investigate some of these other infections, particularly Staph aureus, because historically it was seen to be one of the first and nastiest pathogens, and we thought it was associated with lower airway inflammation. We'd shown that in studies, and if you detect it in the upper airway, well, it often lives there, so it doesn't show that it's causing problems. And so it seemed to be a strong rationale to continue to do BALs when you're studying earlier lung disease. But what Catherine's data showed was there didn't seem to be any difference in outcomes if you got that staph early on. But I wonder how many of you have practiced for some time in CF, how you reconcile that with previous notions about early staph infection. In the days before Pseudomonas, children died presumably with staph infection. And so are there different types of Staph aureus? Are there some that are benign and don't cause problems? Are there some that are actually pathogenic that we weren't detecting in the 90s? And if staph isn't causing a major issue, what's been the concern with prophylaxis, etc.? Could we just treat it in the way that we've been doing empirically with exacerbations and short courses of antibiotics? Perhaps I know, Luke, you've probably got something to say about this, and you've been looking at small colony variants and other pathogenic type staphs that we haven't identified. But perhaps you could comment first, and then we'll come back to Kevin.
I'm going to disappoint you again by not taking a side. Because my first goal is not to make anybody sicker, and I also we all wear antibiotic stewardship hats. There's I would answer I would answer your question informed in part by our experience with small colony variants. There are basically two subtypes of Staph aureus that our clinical labs pay attention to. There are small colony variants, which some labs detect, ours does, And there's methicillin-resistant Staph aureus, which is a lot more common in the United States than apparently anywhere from learning today. And both of them have been associated with worse outcomes in some studies. But for both of them, the biggest risk factor for their being detected is prior antibiotic treatment. So again, we're back to the circular question of whether they are indicators of prior disease or just needing the antibiotics, or whether they're actually the cause. There is some evidence from laboratory studies for each of them that they're more there are subtypes of Staph aureus, including small colony variants, that might be more pro-inflammatory, but they're laboratory studies. They're not, again, these are not human studies. And so I think this is one of the reasons why many of us prefer to just sort of watch and see, and have adopted a treat when necessary approach, the one that Margaret's been talking about. I do think it's possible that there are subtypes of Staph aureus that are particularly toxic. Certainly experience in other infections, such as toxic shock syndrome, sepsis, device infections. There's certainly subtypes that are more toxic in certain clinical scenarios. I'm not convinced that we are able to predict which subtypes are more pathogenic in humans yet. And so that's what I got. And I don't know when we're going to get there. And honestly, if modulators preclude us from ever answering the question, I'd be delighted.
Great. Well, I'll then pass that on, the difficult curly question, on to Kevin. So Catherine had showed no difference in outcomes over 25 years. So could you take us back to the era that heralded the introduction of anti-staph prophylaxis? What were they for? And how did Catherine's data make you think about their value now?
Yeah, so I think across Europe there is more a rationale of treating Staph aureus if it's isolated in cough swabs, oral pharyngeal swabs. I think that's more of a European model coming out of Denmark and adopted very much by the UK. And then the hypothesis of the sort of pathway of infection, I'm not sure that's true. And I think many people are now in equipoise about that, and that's why we're running the study. But I do think there are some hosts who don't do well with Staph aureus. But I think on the whole, most, and we all know as kind of fairly experienced CF physicians, so that we have patients who host a wide variety of pathogens quite comfortably, even really quite horrible things like Cenocepacia and even abscesses, who don't seem to have any significant deterioration in their respiratory condition, even though they seem to be chronically infected with these. I think that probably happens more often with Staph aureus, but I think in some individuals, and it's all down to the host pathogen relationship, in some individuals it is significant. If we identify it in the lower airways, we would very actively treat it. I haven't answered your question, have I, Sarah? But I think it's fascinating that we have this dichotomy across the globe. I think in Europe there's a gentle shifting, and now as we move to modulators, I think what modulators are going to do is have a direct impact on that host pathogen relationship, hopefully in a positive way. I wasn't massively taken with the lumacaftor ivacaftor data, Luke, but I think as we move to having what are generously called highly effective modulators by pharma, I think that's going to be quite significant then. So yeah, I haven't answered your question.
Well, Luke's got his hand up.
Can I add one thing I wish I'd said before?
Yes.
In addition, Sarah, you specifically asked about subtypes of Staph aureus, but there are a lot of other potential determinants of differential effect on people. Kevin just mentioned the host. There is also, if we categorize patients as having versus not having Staph aureus, that ignores, that doesn't consider the abundance of Staph aureus, which is something that Catherine talked about. And really information that we don't really collect very often, but also the anatomic location, which people have also referred to. So there are a lot of potential reasons why some people may have a more difficult time with Staph aureus, because it's more abundant, because it's a specific subtype, because it's localized to one particular place, which we don't sample in or characterize in a very granular way. And so I think just if we're going to do studies where we categorize patients according to whether they do or don't have an organism, that there's a high likelihood that we're not going to find what we want to find or study what we want to study.
We don't have too many minutes left, and there have been a couple of questions about non-tuberculous mycobacteria, which really none of us discussed today. So, Luke, what is known about the effect of hemp on incidence or prevalence of NTM?
Well, because I'm a pediatrician and because it's a relatively rare organism in my patient population, the short answer is I'm not sure. I have heard some encouraging preliminary asides from other people, but I'm no expert, and so I really shouldn't be telling tales out of school. I think many of us are hopeful. I can tell you from personal experience that I've had a couple of patients who were persistently culture positive who have converted, but that was with antibiotic therapy at the time of starting Trikafta, and some patients who are still persistently affected who have stabilized clinically. But again, that's anecdote. That's not data. That's not science. And I welcome anybody else's observations about this.
Okay, a couple of folks also asked questions about azithromycin. And so I guess I would frame those questions in the following way. Is there a role for consideration of discontinuation of azithromycin in people on hemp? Sort of a simplify study for azithromycin. Don't all answer.
I don't think we're quite. I think most of us are feeling comfortable with withdrawing mucolytic therapies, but I think at the moment I don't think we're quite there to do the study of withdrawing antimicrobial therapies. Although azithromycin has this mysterious anti-inflammatory possibility. What do you think, Margaret? I think that's the next step, really.
I'll wax into anecdote fairly quickly here. You know, the studies of azithromycin have mostly been around its effect on reducing the risk of exacerbations, which is dramatically lowered by the use of hemp. And so I do wonder whether there might be a role for evaluating taking people off of it in the hemp era. There's also the whole connection from the optimized study with decreased exacerbations in the setting of initial infection with Pseudomonas. It didn't in that study have any effect on time to chronic infection, but that's maybe in part because the trial was prematurely discontinued due to efficacy in terms of exacerbations. So I think, I don't know, I guess there's no way to channel Dave Nichols here. He would know, but I wonder if there aren't some studies being planned around trying to take people off. And then, of course, the COVID pandemic also dramatically reduced the rate of exacerbations as well. I don't know, Luke, if you have anything to add.
I wouldn't. No, I don't. I wish David were on the panel right now, because I'm sure he would have plenty to say about it. He would.
Okay. And speaking of him, I think we'll end with one last question, which is from Dave Nichols. And he asked, and this is for you, Luke, I think if modulators that improve CFTR function and mucociliary clearance are quickly having such a large effect on Pseudomonas, both in terms of detection and density, does that shed light on where in the airway these bacterial species predominantly exist?
Oh, boy. I think it makes that's a really good question. We had a really nice presentation this morning at a workshop by Sarah Morgan from Pradeep Singh's lab about that. I I think this is still an area of controversy, and I think there are multiple models that could explain or account for the decrease in specific organisms abundance relative to others. A very good model, a very plausible model, is that all of the Pseudomonas, for example, or Staph aureus in a sputum sample that people are looking at comes from the lower airways, whereas everything else comes from elsewhere, such as saliva or somewhere else. That is one model. It's also possible that sputum changed, that the location of sputum, and the contributors to sputum changed, and that there are many potential anatomic contributors to sputum. That includes not just the lower airways, but also the sinuses. We know that a lot of these traditional pathogens also concurrently and sometimes even precede, infect earlier than in the lower airways. And I haven't really been able to find a good description of, in an average CF patient, how much of a sputum sample comes from deep versus how much of it comes from postnasal drip. I suspect it's not the same in everybody. And it's plausible that it might change after modulators. It's also possible that there is a change in immune capacity or immune function that clears certain organisms from the lower airways faster than others. And again, I prefer to remain agnostic until we understand this a lot better. And I like to allow for the possibility that the answer is not the same in every patient. But it's going to get harder to study. We may never be able to answer that. I have a really hard time with this, and I've definitely had some very spirited conversations with other people about exactly this question, because I think it matters quite a bit.
Well, we're just
again, I would absolutely welcome other people's input on that question, by the way, because that one makes me uncomfortable.
We're unfortunately at the 1:15. So Luke, you will remain the sole responder, but Sarah and I would just like to thank everyone so much. Both the speakers and the audience. This was a really spirited and wonderful session. And thanks everyone so much for joining, and have a great rest of your day.
Thank you for attending and inviting.
Are they all gone now? Are we finished? Yeah. Thanks, Margaret. Thanks, Sarah. Lovely. I'm going to go and watch some football now.